beds we use and even on dialysis. So I think having, my first thought was, I don't need to hear about dialysis, but a general understanding is probably a good idea. So let's start with a case, and this is a real case that came to our ER from Sumter about 6 years ago. So MS is a 15-year-old African-American male, previously healthy other than obesity, came to the ED with just a 5-day history of fatigue. Now, he also turned out to have some non-bilious, non-bloody emesis, but the rest of his review of systems was completely negative. His past medical history, including his birth history, were non-contributory. Family history, his dad had hypertension. And on exam, he was hypertensive and a BMI of 40, but the remainder of his exam was completely normal. And then his labs came back. So he is my record in my career of a serum creatinine of 32. And I think this is an unusual case, but is a good case to remind us how insidious and silent chronic kidney disease can be until its advanced stages. Thus the importance of having an awareness of it. Obviously, he was urgently managed in the PICU, put on dialysis, and unfortunately passed away in adult care last year. All right, so the definition is kind of a textbook definition, but I'll read through this. It's kidney damage for 3 months or more, defined structural or functionally by abnormalities such as labs, imaging, or kidney biopsy. But the important part is you can have chronic kidney disease with a normal creatinine, with a normal GFR. So you do not have to have abnormal labs to have it. A great example of that would be a diabetic with proteinuria or sickle cell patient with proteinuria. They would be deemed chronic kidney disease, even though they may have normal renal function. And the way we define it precisely is by glomerular filtration rate, something that you, like me, probably hated in the first 2 years of medical school. Its units are ml per minute per standard meter squared for an adult male, 1.73 meters squared. And perhaps the best thing for you to remember is it's easy to estimate by the Schwartz formula. And this is a creatinine-based calculation. And the Schwartz formula has been simplified over the last few years. The K factor of 0.413 used to be one of 4 different K factors that you had to remember. Now you just have to remember one. So you take that factor times the height in centimeters, divide that by the serum creatinine, and that estimates your GFR pretty well. Now, a creatinine-based formula for estimating GFR is flawed by the fact that anything that can change creatinine production or secretion is going to alter the end result. So along comes the cystatin C test, and our hospital does this very easily, same day information. It is a low molecular weight protein that is filtered by the glomerulus and not reabsorbed. It is produced by all nucleated cells in the body at a constant rate, and it is not influenced by muscle mass. So our scenario in clinic would be, a teenage male who's a bit muscular gets labs for some reason as part of well childcare, and the creatinine comes back 1.16 and flags high, and then they get referred to us. And so we will use the cystatin C to prove that that creatinine is normal for that kid. So it's useful when you do your repeat. If it's kind of, if it's obvious, if it's 1.8, you're not going to need the cystatin C. The staging of CKD, you don't really need to know. It's 5 stages. Stage 1 is normal GFR. Stage 5, I need dialysis, okay? And everything in between is mostly a billing issue. So we are encouraged to calculate a GFR and use the right code based on that. But clinically, it doesn't matter except this general principle. And this is sort of intuitive. As you progress, you have more complications, okay? And that's kind of obvious. But the problem is you never can predict at what stage this complication is going to develop. So all kids with CKD get screened. And so that's why it's not necessarily all that useful clinically. So epidemiology, as I mentioned, is kind of tough, and it's difficult to estimate because kids are often asymptomatic. So there aren't really good, robust studies, but what there are is data repositories. And I'm using the USRDS report here, this United States Renal Data Service. So that's a pretty robust compilation of data over time. And so the milder forms, we don't really know how to estimate, but severe chronic kidney disease, stage 5, end-stage kidney disease, we have some statistics. So the annual incidence is about 15 per million when accounting for all ages birth to 19. And in 2015, which led to the 2017 report, there were about 1,400 new cases a year of pediatric dialysis. Okay, so this is again end-stage kidney disease. Prevalence 90 per million, and at any one point in time, about 10,000 kids. Now these numbers pale in comparison to adult data, obviously, but it's not insignificant. And I'll tell you as an aside, here at our medium-sized academic center, we manage between 8 and 10 kids on dialysis. So that's a pretty high number for the size of our city and the size of our program. Males predominate worldwide, and minorities predominate over Caucasian patients as well, and that includes Hispanic patients, not just African. So etiologies in the adult world, it can be simplified to 3 diagnoses, and that's being unfair to my adult colleagues because there's more to end-stage kidney disease or chronic kidney disease. But hypertension, diabetes, hypertensive nephropathy, diabetic nephropathy, and autosomal dominant polycystic kidney disease. I think I can say this, never see advanced chronic kidney disease from those 3 diagnoses, okay, because they take a while to develop. Do we see diabetes with proteinuria? Yes. Do we see a lot of hypertension? Oh, yes. Do we have a lot of kids with dominant PKD? Yes, but they don't develop abnormal creatinines until the 4th or 5th decade of life, okay? So it's boring in the adult world, it's more exciting in the pediatric world. So our etiologies vary with age and race, and our #1 cause is CACET. And this is a relatively new term in the last 5 years or so, principally, and stands for congenital anomalies of the kidney and urinary tract. So that accounts for 50 to 60% of all children with chronic kidney disease, when all stages are included, okay? And because the data are a little bit sketchy, you'll see me kind of go back and forth between chronic kidney disease all-inclusive and end-stage kidney disease, or stage 5, which has a bit more data that we can look at. So if you look at end-stage kidney disease from birth to 21, you see that there's kind of this even mix between primary glomerular disease and CACET, and that's because you have a lot of 13 to 19-year-olds in that data, or 21 in this particular study or report. We also see a lot of cystic, hereditary, and congenital diseases, and then the secondary glomerular diseases are vasculitides, interstitial nephritis, pyelonephritis, transplant failure. Diabetes, again, I would argue is not 1%, it's probably closer to 0. And then the ever popular unknown miscellaneous category. And we're going to talk about what these diseases are in a second. So full disclosure, this is my only up-to-date slide, but I love this graph, okay? Because what this graph shows is the progression of etiology at the time of transplant. So again, stage 5 CKD, from 0 to 4 on up to 18 to 21. And what you see is that looks pink up there, but what you see is the CACET bar, okay, is shrinking the older you get, and the bottom bars, the primary glomerular disease, is getting more common. So it's just, again, showing the change in primary etiology with age. So CACET itself can be broken down into 3 categories, and a lot of these diagnoses you are all very familiar with, okay? So parenchymal malformations include dysplasia, hypoplasia, aplasia, collecting system anomalies, obstructive uropathies like posterior urethral valves, UPJ obstruction, Equal-Barrett syndrome, high-grade reflux, duplication, bladder exstrophy, cloacal anomalies. Migration abnormalities, the ectopic kidney, the pelvic kidney, or the horseshoe kidney would fall under that category. And CACET in total is about 1 in 500 births. So it is super common, okay? Now, the obvious thing when looking at that incidence and when looking at the diagnoses is many of them do not cause chronic kidney disease. Horseshoe kidney, I mean, you know, unilateral aplasia, born with a solitary kidney, you do fine, okay? So, but those are the diagnoses that fall under the heading of CACET. Glomerular disease is broken down primary and secondary. So FSGS is far and away the #1 glomerular disease that causes chronic kidney disease. followed by MPGN, IgA nephropathy, and membranous disease. And then the secondary diseases are glomerular involvement from lupus, HUS, ANCA-positive disease, and again, the idiopathic crescentic disease, because we just haven't figured out what the diagnosis is. And once you hit 13, the glomerular disease incidence as a cause of CKD becomes the more common. Cystic hereditary genetic diseases would include recessive polycystic kidney disease, which is very rare, dominant 1 in 1,000, recessive 1 in 40 to 60,000, okay? But it's a bad disease. So it leads to end stage in pediatrics when you have it. Nephronophthisis, just a fun word, hard to spell, is a medullary cystic disease. We've had a couple kids here with that. You've all heard of Alport syndrome. The congenital nephrotic syndromes are genetic in that they have an identifiable gene that's mutated that causes the disease. Cystinosis, oxalosis, and then syndromes, okay? And those are a collection of the syndromes where we see a higher incidence of chronic kidney disease. One of our transplant patients who was just in the hospital, Kingston, has Meckel-Jobert. He's pretty much our only one in our practice right now. And then if any of you have ever met Mason Mack, he's a transplant patient that has Pearson syndrome. So, just things to think about. So risk factors for either the development of chronic kidney disease or the progression of chronic kidney disease are very important to be aware of and very germane to general peds practice. So the non-modifiable, the things we can't do anything about, are low birth weight or prematurity, decreased renal mass, okay? So, you had a resection or you had from a tumor, or you had hypoplasia, you have decreased mass from that, or scarring, et cetera. A history of acute kidney injury, and then a low GFR begets progressive loss of GFR over time. Modifiable things are things you see every day, like hypertension and obesity, but also proteinuria. Remember, proteinuria is a double-edged sword. It represents chronic kidney disease and causes more chronic kidney disease because proteinuria is very scarring to the glomerulus. The glomerulus does not like protein passing through it. Anemia, chronic anemia, which is a big problem for our CKD population, can lead to progression. Smoking and metabolic acidosis, which is something we pay close attention to as well. This does not bear out in a statistically significant way, but hyperlipidemia is a theoretical contributor as a modifiable risk factor. So everything starts with a full history, and I tried to dumb this down to the more pertinent things. So anytime you are looking at a kid with early chronic kidney disease, birth history is very vital and important. History of urinary tract infections that could have resulted in scarring, history of acute kidney injury, as I mentioned a minute ago. Growth and development. I know you're going to look at growth and development as part of your physical assessment, but we also ask, has there ever been as a subspecialist, we ask mama, has there ever been a concern about following the curve or meeting milestones on time? And then a family history of relevant inheritable renal disease certainly would be pertinent. Systems review, fatigue. Again, uremia is fatiguing. And so I think that's why Dr. Carney felt like it'd be a good talk for this week. A loss of appetite, nausea and vomiting that's unexplained. It's often in the morning with uremia, which is very unusual. Urinary symptoms, polyuria, nocturia, enuresis. Remember that cacket diseases, okay, particularly dysplasia, hypoplasia, are tubulointerstitial diseases, not glomerular diseases. And if you have tubulointerstitial disease, you don't concentrate your urine normally. So you are relatively polyuric, not oliguric, which everybody thinks with chronic kidney disease, okay? So taking a history of, kids should not get up in the night to pee, especially school-age kids. So if they do, that's a little bit unusual. Secondary enuresis. This is not going to be the polyuria of a diabetic or a DI patient. It's not going to be that obvious, so it requires some questioning. And constipation is key because the more chronic water loss in the urine, the drier and harder the stool gets, and you get constipated. So there's a direct connection between water loss in the urine and constipation. Because they can't concentrate. And, you know, to take this a step further, you know, how often do you see kids and y'all dip urines for well child checks or whatever, and you're like 10:25, 10:30, and you're like, dude, you got to drink more and get off soda, caffeine, etc. And then when you see that kid with a 10:10, you go, oh, you're awesome. And I'm not saying work up every kid with a 10:10 spec graph, but go, that is so unusual in school age kids. It should lead to just some other questions, okay? Because a lot of these kids say, can't get above a 10:10 or a 10:15. You're not going to be 1.000 like the PI patient. And we had a kid here a few years back who was 6, had chronic constipation, got admitted for impaction, and they imaged his belly, and he had massive hydro and had posterior urethral valves that nobody knew about for 6 years. So a lot of this can escape perinatal detection, and that's why the history of now, please don't do a renal ultrasound on every kid that's constipated. Your attendings will yell at me for that. So low yield there, but think about it. Ask a few more questions. Dyspnea, orthopnea, and edema are up there just to represent those rare kids that have volume overload, but that is rare for us. They're going to be older kids, and they're going to have glomerular disease, not CACIT, because CACIT kids pee through dialysis and on. They never get oliguric, okay? So again, it's kind of opposite what we often think. Physical exam, blood pressure, vital, right? That is huge. Growth parameters, any dysmorphic features, and again, physical exam findings suggestive of anemia or volume overload are worthy of noting. So what are our complications? So this is the list that I just created that we could go through. Growth and nutrition, one of our biggest frustrations with CKD kids. Mineral and bone disorder, anemia, neurocognitive effects, cardiovascular disease, and the bottom line is that the mortality risk is huge with chronic kidney disease, unfortunately. Now, the good news for us as pediatric nephrologists is that it's rare for kids to die in the pediatric lifetime, but they do not have a very long lifespan if they have the origin of their CKD in childhood. So let's take one at a time. Let's talk about growth and nutrition. And failure to thrive is a big problem with uremia, with CKD. And it is, in fact, the perfect storm, because look what happens. They have increased needs over their well peers. They don't want to eat. They're not hungry. They have anorexia. They have altered taste, so things that used to taste good to them no longer do. They have early satiety, so the parents will say they just take 3 bites and they're full and they won't eat anymore. And then we place all of these dietary restrictions on them just to make matters worse. Then other things can contribute, like metabolic acidosis and being in a negative sodium balance. So a lot of CACIT kids, again, a tubulointerstitial disease, are salt wasters. We don't really know. And there's a lot about this that has to do with uremia or uremic toxins that are unmeasurable, that we haven't discovered, but it's blamed on the uremia. It's blamed on the BUN and that the altered taste and early satiety. Babies, I didn't put this up here, but babies that have CKD, you know, all babies reflux, right? That's the old adage. Well, uremia makes reflux way worse as well. So a multifactorial contribution to growth failure in kids, and again, nutrition, genetics, bone disease, metabolic acidosis, sodium and water balance, loss of, and when you get to stage 5, loss of your residual function, because remember, even if you have a GFR of 12, that's something that can go with the GFR generated by dialysis. And if that 12 goes to 0, then it's worse. And so you're going to more likely have growth and nutrition issues. Inadequate dialysis, something we look at in that population. Do we have you on the ideal prescription for you if you're not growing or not thriving? And then anemia contributes as well, keeps showing up. I don't know if y'all remember Gary Coleman from Different Strokes. This is a long time ago. But Gary Coleman was short because of chronic kidney disease, okay? He had FSGS, and when Gary Coleman presented and throughout his life, we did not have growth hormone, okay? And so I always say that we can now avoid the Gary Colemans of the CKD world in children. So, but short stature is a big problem, even when nutrition is adequate. So by stage 5, a fourth of kids are below the 3rd percentile for height. Poor nutrition most definitely contributes to linear growth or the lack thereof. This is not a growth hormone deficiency state. It is a disturbance of the insulin-like growth factor, growth hormone axis. I'll show you a couple of pictures of this. It's not important that you know the details of that, but if you measure growth hormone levels in these kids, they're normal, yet growth hormone works. Okay, so we are super saturating growth hormone receptors because they may be less in number due to the lack of IGF, as you'll see. Poor growth has a negative influence on psychosocial development, and the shorter kids have a higher mortality, interestingly, probably due to there being that reflecting that a lot of other abnormalities are at play. And, you know, I just had a talk with a kid who's got stage 3 chronic kidney disease in my office this week, and she is 8, and I've been following her since birth. And we finally got her weight on the curve, and she's doing great, but her height is not progressing. And the parents, you know, were a little uneasy about growth hormone therapy. And we had a long talk about the psychosocial impact of her. She gets into middle school and high school, and she's significantly shorter than her peers, and what impact that's going to have on her. So after that discussion, they're going to do it. So very simplified version of growth hormone being produced goes to the liver, promotes the secretion of IGF-1, insulin-like growth factor, which has a direct effect on bone, on muscle, on skin, and promotes growth. And it is that axis that is altered in chronic kidney disease. A little more complicated slide, but again, in the purple box, pink box there, uremia and other complications will lead to a decrease in IGF-1. And then that decrease in IGF-1 and some down regulation of growth hormone receptors that you see in the center of the person contribute to poor linear growth despite adequate calorie intake. So what do? Well, it's aggressive calorie support first. If you are in the first year of life and have moderate to severe chronic kidney disease, 100% of the time you're going to do G2. And this is a really tough sell to parents. You know, one thing that parents in a kid with chronic disease feel like they still have some control over is feeding their baby. And there's a notion that if we do a G-tube, they're not going to be able to feed their baby anymore. And so a long discussion ensues about how this is meant to augment what you're doing, not replace what you're doing. And as we are discussing the fact that the baby's got failure to thrive and you're spending 20 hours a day trying to get bottle feeds into this baby, trust me, the G-tube is going to make your life a lot easier. And y'all have been at this a while. Every parent that I've talked into a G-tube has come back in and said, thank you, because they can focus on just loving the kid and feeding normally and know that they have a backup plan for nutrition, okay? There are renal formulas available. I'll show you what they are. They're renal because they're low in potassium and phosphorus relative to standard formulas. And then very often we need extra protein. So, you know, the adult approach is restrict protein to marginalize uremia. We do not do that in growing children. And in fact, even our teens that are on dialysis will often have low albumins, not reflective of urinary losses or liver disease, but reflective of protein malnutrition. So we put them on protein supplements. Renal vitamins are renal because they're low in vitamin A. That's the only difference. If you put a kid on standard amounts of vitamin A over years with CKD, they can become vitamin A toxic. And then once we have poor linear growth in the face of good calories, we initiate growth hormone therapy. Unfortunately, it's only sub-Q, which is why a lot of parents are apprehensive about it. So here are some classic renal formulas. The one you may be most familiar with is Similac PM6040. We have a lot of kids in the first year or two of life on this. It is regular Similac with less potassium and phosphorus in it. Nepro and Suplena are good for older kids and adults. It tastes nasty. So, you know, the beauty of a G-tube is we can do dilute versions of these adult formulas and say a 3 to 6 year old, if they still have their G-tube, and give them the nutrition they need. Renastart and Novasource Renal are newer, taste a little better, but I'm telling you, most renal formulas taste terrible. So it can be a struggle.
You know what the 1640 stands for?
No, that is a great question. But you can tell me before your rotation. All right, breast milk is a wonderful renal formula. So if you have an infant and mom wants to breastfeed, we encourage it wholeheartedly. Breast milk is lower in potassium and phosphorus than standard formula. So we like breast milk. There are times, I'll tell you, that we run into some potassium issues, and you may see patients come in who are either on express breast milk or PM6040, and they decant the formula with Kexalate. And this is a real nifty way to take a low K formula and make it a lower K formula. And they add a simple prescribed amount of Kexalate powder or liquid to their made formula for the day. They do the martini shake and they put it in the fridge for an hour. And what happens is a sludge settles to the bottom of the container and it contains the potassium. They carefully pour off the top layer, and that's the baby formula for the day. So we can get, it is unusual for CACIT, because we're talking about infants here who are mostly going to have CACIT. It's unusual for them to have potassium problems, but when they do, we have a medical therapy so we don't have to prematurely start them on dialysis. All right, the next big category is the bone disease, and this is now called mineral and bone disorder. And I know that most people can't stand when Stallworth tempts them on bone mineral metabolism. It's one of his favorite things, as y'all know. So my recommendation is that you just know the players and you remember the jobs of two of the players. And this physiology will help you figure out calcium disorders outside of the kidney world, okay? So calcium, phosphorus obviously are our mineral players. Parathyroid hormone is important. It maintains serum calcium. The reason you have a parathyroid gland is so you don't die of tetany, okay? Its second job is to pee out the phos. And a resident several years ago said, oh yeah, I know that because PTH is phosphate fraction hormone. I'd never heard that through fellowship or anything. So I was like, that is really cool. So if you know what PTH does, it raises calcium and it lowers phosphorus normally, then that helps you figure out a clinical puzzle or a test question with that. 25-hydroxy-vitamin D, your nutritional vitamin D, is important, more important than we once thought in kidney disease. And then 1,25-dihydroxy-vitamin D, your active form of vitamin D, it's the other one that you need to remember the job of it. So gut absorption, calcium and phos, okay? And then it suppresses PTH transcription. So if you're absorbing calcium and phos from your gut and turning off your PTH a little bit, then you see the benefits of active vitamin D, okay? So simply put, when you have a low calcium, the calcium sensing receptor is deactivated and PTH goes up, okay? And what PTH does then is cause calcium to come out of your bone because it doesn't want you to die of tetany. It causes a decrease in calcium in the urine, which is minor, okay? And it causes some intestinal absorption. So if that is unbridled, you see what can happen to bone. So you have this unsuppressed release of calcium from bone, and that is indeed what happens in kidney disease. The patients develop a secondary hyperparathyroidism. So as GFR declines, you develop vitamin D deficiency and hyperphosphatemia. Vitamin D deficiency causes your calcium to transiently drop because you're not absorbing it anymore. And the low calcium and the low phos stimulate PTH production. Okay, so vitamin D deficiency can be nutritional in the early stages. CKD is a chronic disease. We talked about the nutritional issues. We used to ignore 25-hydroxy D levels in CKD because it didn't matter, right? Because you can't activate it. You can't 1-alpha it, okay, because of the kidney disease. But we've now learned that you can bring PTH down in stage 2 and 3 chronic kidney disease by just repleting nutritional D. Okay, so we're back to using that. If you do bone biopsies on kids with end-stage kidney disease, you'll find altered bone histology in up to 70% of them. So it's a very common complication, okay? And it's manifested in at least one of those that are listed there. Abnormalities in your mineral, PTH, or vitamin D levels abnormalities in bone mineralization, turnover, or strength, or extraskeletal calcification. And the extraskeletal calcification in the world of pediatric nephrology is relatively young, new. It promotes cardiovascular disease. Okay, we used to not pay much attention to that. And an example is calcium phosphorus products, which our adult colleagues always tracked in their patients, but we were like, cardiovascular disease, we don't deal with that, but now we do. Okay, so if this goes untreated, you develop renal osteodystrophy or renal rickets, manifested as what you classically know to be rickets from any other cause: osteopenia, bowing, genu valgum, metaphyseal abnormalities, frontal bossing, rachitic rosary. We'll look at some pictures here in a second. Renal osteodystrophy affects growth. They can develop bone pain and pathologic fractures in advanced stages, more likely have slip epiphyses, and it can actually start to affect the muscle. So this can be pretty devastating to the kid. And the management of this, as you'll see on another slide, is the number one cause of the number one non-compliant part of our management. It is very frustrating. If the secondary hyperparathyroidism goes on and on and on untreated through non-compliant or not seeking care, then you develop tertiary hyperparathyroidism, and that is to say the PTH, the parathyroid gland, has undergone an adenomatous change and will never be shut off and has to be removed, which has its own problems. Extraskeletal calcifications can occur in the vascular system, in the eye, around the joints, and in the viscera, and again can promote cardiovascular disease. So upper left, genu valgum; middle upper, bowing; right upper, rachitic rosary; bottom left, frontal bossing; bottom right, metaphyseal widening, flaring, cupping. So a lot of this, these are pretty advanced stages of rickets, but things that you should look for in your physical assessment of the patient. We're going to talk about that. There's a slide on it. All right, what do we do for the bone disease? Optimal management of serum phosphorus is our biggest frustration. Okay, so extensive dietary counseling. So where is phosphorus? Dairy, soda, and processed foods, right? And processed foods are the biggest problem because processed foods are preserved with phosphate-containing chemicals. And when you have families with teens, or you have families of younger kids with meager means who rely heavily on these foods, it is a big problem. So we go through all that. The dialysis patients will meet with dietitians, but short of that, it's up to us to kind of review diet and be sure that they're adhering to a phosphate restricted diet. And then if they are, and the phosphorus is not normal, we bind it. Okay, so phosphate binding is medication you take with your meal, and the medication binds the phosphorus in the meal and you poop it out. Okay, so a very effective way of controlling phosphorus, but the number one source of non-compliance in CKD is phosphate binder therapy. Okay.
I mean, is it like taste? Like, I mean, it's not like Tums doesn't taste. Like, do the other ones taste? Or like, is it just like can't figure out when they're supposed to take it?
Yeah, it's not a taste. Yeah. There's no side effects. There's no taste. Well, Tums has a chalky. That can be a problem sometimes. You can try the smoothies. You can try the fruit flavored. You have to come up with whatever the kid will do. And oftentimes we jump from one to the other because we learn they're non-compliant. We say, well, will you try this? Yeah, I'll try that. And they're not taking that. The number one reason is that it's a lot. And they have to take 2, 3, 4 of these with every single meal. And they don't do it. It's a pain. Okay. Yeah. Yes, it's not a taste or side effect problem. Yeah. Yeah, it depends on age and it depends on how high the phos is. So I'd say the starting dose would probably be 1 or 2, 3 times a day. And again, breakfast, lunch, and dinner. And if you have a snack, we want you to take one with that. Okay. What are they? Calcium-based or calcium carbonate Tums in pediatrics, that is the most common one. That's the one we're always going to start with. Calcium acetate or Foslo is used more in the adult world, but is safe for kids. I didn't, Tums, calcium carbonate comes in a capsule you swallow whole. And so it's a 500 milligram elemental. So it's like a Tums Ultra. Remember, there's Tums regular, extra, ultra, 2, 3, 400 milligrams elemental, I think is. But y'all, this is a problem in the hospital. This is not weight-based dosing. This is Tums. Okay, so we just start and we titrate. Okay, but if they're refusing to chew Tums because they say they're chalky, then we'll see if they'll swallow a calcium carbonate capsule. And if they'll do that, the only nuance there is instead of chewing Tums right after you eat, we say take that pill right before you eat. Because if it's a whole tablet, it's got to dissolve to do its thing. So a little bit of a timing variation. Sevelamer, Renagel, Renvela are the brand names, is like a plastic polymer in a capsule or a packet of granules. So it is a non-calcium containing phosphate binder with very little, if any, taste whatsoever. And it's a good option, especially in kids if calciums are running high, right? We're putting you on all this vitamin D, and we're doing that to get your PTH down, but it might drive your calcium up. And then your calcium phosphorus product is an issue. So then if that's the case, even if you're compliant, we may switch you to a non-calcium containing phosphate binder. And then a newer one is ferric citrate. We have a couple kids on this. It's an iron-based formulation. And I've had kids that take it and they wouldn't take anything else. And sometimes they come off their oral iron because it gives them a little bit of extra iron as well. For vitamin D deficiency, we may start with traditional nutritional supplements, 2,000 to 8,000 units daily, depending. Our target is the vitamin D level above 30 to allow the PTH to trend down. A lot of benefits of vitamin D. Y'all know this. It's the wonder vitamin, right? It's more than a vitamin. It's a hormone and all these things. So it helps with inflammation, obviously improves PTH. It can reduce your need for ESAs, which is erythropoiesis stimulating agents that we're going to talk about in a second, and has a theoretical benefit on cardiac dysfunction. So unlike 15 years ago, we start with 25D first and see where we are. Now, if you have an elevated PTH, but your 25D is normal, that's when we'll start calcitriol. Okay, calcitriol is the 125 dihydroxy active form. Comes in 2 strengths. It's a teeny little capsule, comes in a liquid, so it's easy to give to little kids. The liquid preparation sticks to plastic. So if you have a kid with G-tube feeds, the mama still has to give the liquid calcitriol by mouth. We discovered that some time ago, and we had all these babies that had refractory hyperparathyroidism, and it was determined that they weren't getting it because it was adhering to the plastic of the tube. This too is not weight-based dosing. Okay, and again, inpatient pharmacy gets kind of wigged out by this. We just start a dose and we titrate, okay? And we titrate based on a PTH target. And as you can see in the minor stages or the milder stages, we target essentially a normal PTH. If you look at parathyroid hormone, you'll see, I think 65, 70 is the adult upper limit of normal. But as you progress, we put up with a higher PTH. And in fact, at end stage, we allow you to be 200 to 300 and are happy. Now, whenever there's a case here of a calcium disorder and a PTH abnormality, I'll often hear, oh, the PTH is super elevated at 250. And I laugh because our dialysis teens have PTHs, unfortunately, in the thousands, 1 to 2,000, sometimes 3,000. Those are non-compliant teenagers. So, but our target is 200 to 300. Now, the reason we allow for an abnormal PTH is we learned this. If we oversuppress, what we do is we shut off bone remodeling. PTH's job on bone is osteoblast, osteoclast, bone, lay it down, resorb it, and that's how bone stays healthy. So a bone biopsy study several years ago showed a lot of kids had a dynamic bone because their PTHs were oversuppressed. So in the late stages, we allow mildly elevated PTH. There are other analogs out there you don't have to know. There's their names. They have theoretically less calcemic effect than calcitriol does. So if that calcium phosphorus product is an issue, you can switch to those. And then the newest class is the calcimimetics, and cinacalcet or Sensipar is the drug of choice here. It's a really nifty drug. It basically binds the calcium sensing receptor on the parathyroid gland and tricks it. So the parathyroid gland thinks the calcium is great and shuts down, okay? And this is only recently FDA approved in children, and the FDA approval is getting younger. So we're excited about the use of this. The biggest problem with it is hypocalcemia, because you really are suppressing that PTH. All right, next big category, anemia. So this is, as it says, one of the most common and clinically significant complications of CKD. You know, the kidney is the most important organ in the body. It does a lot of things other than pee, right? Make pee. So it makes your erythropoietin. And if you have diminishing GFR, your erythropoietin production goes down and you become anemic, okay? This is linked to hospitalization, cardiovascular disease, and overall mortality. And then as you progress, which is obvious down the stages of CKD, you can see the prevalence of anemia related. In fact, greater than 90% are anemic at stage 5. So a very common problem. Causes are actually more than just EPO deficiency, okay? But that's a big part of it. Iron deficiency, because CKD is a chronic disease, is always playing a role there, okay? Systemic inflammation, which uremia is, and infection. Chronic blood loss from phlebotomy, excess phlebotomy in younger kids, but more commonly on hemodialysis, HD, circuit blood losses contribute to anemia, excess menstrual bleeding, and sometimes GI blood loss. Hyperparathyroidism untreated makes the bone marrow resistant to EPO. So that's why hyperparathyroidism contributes to anemia. A lot of our kids are on ACE inhibitors or angiotensin receptor blockers for their blood pressure or for their chronic proteinuria, and that can contribute to anemia. Hemolytic anemia, those mystery uremic toxins. And then we have to think sometimes outside the box to other nutritional deficiencies that could contribute to anemia, like carnitine, folate, and B12. What does it do to you? It makes you tired, makes you depressed, it alters your sleep. And this is a typo I found just before coming over here. It's either got to be decreased exercise tolerance or increased exercise intolerance. You don't exercise as well when you're anemic, right? That should be obvious. It affects your cognitive function. It contributes to loss of appetite. It contributes to the development of LVH, cardiovascular disease, and it affects your overall quality of life. So what do we do for it? We are sure that you are iron replete. So that's the first step. And you must have normal and available iron stores to support hematopoiesis, whether you're going on EPO or not. So even if your iron's normal and we're going to start you on EPO, we start you on iron. It's practically never do you use EPO without iron. It can be given orally or IV. So this is great for our hemo population, the iron can. The dose is what you're accustomed to, right? 3 to 6, 3 if you're good stores and 6 if you're deficient, kind of in that range of elemental iron in milligrams per kilo per day. In the kidney world, our target is a % saturation greater than 20 and a ferritin greater than 100, okay? And the combination of those two supports not only adequate stores, but adequate availability to use iron for hematopoiesis. Ferritin is flawed because it's an acute phase reactant. So a lot of kids with stage 5 will run 800 ferritins, and then we just focus on the % saturation. We don't say that's a contraindication to giving them iron because we recognize that it's falsely elevated, if you will. The 2 preparations that we use for IV supplementation are Venofer and Ferlicit, iron sucrose, iron gluconate. They're safe. You know, the old iron dextran where you had to do a test dose and kids had reactions to it. We don't use anymore. These newer preparations are much safer. Then our ESAs, okay, our EPO. So recombinant erythropoietin was FDA approved in 1989, and the general span of medicine is pretty recent. So up to 1989, all patients with chronic kidney disease that had anemia were transfusion dependent, like sickle cell patients are, and therefore had all the inherent complications that went along with that back then, more infection, certainly iron overload, and that sort of thing. So EPO revolutionized the management of chronic kidney disease. Now, most patients are on it sub-Q, so we got to be on top of compliance. It stings a little bit. It's like an insulin syringe, but the preservative in it can cause a little bit of burning. It can be given IV, and that is what we do for our hemo kids because we know they're getting it. They're connected on the circuit, and the nurses can give it there. But the half-life is better sub-Q, so it tends to be more effective if you give it sub-Q. Our goal is the starting dose is about 50 units per kilo per dose 3 times a week. That's just a rough kind of thing. And then you titrate to effect like everything else. We'd like your hemoglobin to go up by 1 gram or 2 a month, and we'd like you to settle around 11, okay? Now, I'll tell you as an aside, dialysis units have to curtail cost, and a lot of medications in dialysis cost is reimbursed by the federal government. And if the dialysis unit lets patients run a hemoglobin of 12, the government will refuse to pay for the EPO. So adults tend to run a little bit lower to curb cost. We do our best to keep our kids in that 11 to 12 range as best we can. So our options are epoetin alpha, which is Epogen or Procrypt. And then there's a newer preparation called darbepoetin alpha or Aranesp, as well as this methoxypolyethylene glycol epoetin beta or Mircera, which these are depot analogs of epoetin. So they can be given once or twice a month, which is better from a shot perspective. But we find they don't work as well or as quickly. So sometimes what we'll do is if we get your hemoglobin at target, then we can convert you to a depot preparation and keep an eye on you, allow you less shots. Oh dear. All right, so again, iron deficiency, hyperparathyroidism, inflammation, and the development of erythropoietin antibodies all contribute to EPO resistance. Neurocognition is no doubt affected by uremia, and this is a big deal in our younger kids who are watching closely through their developmental milestones. Yet another way that the general pediatrician helps us tremendously to sort of be on top of that. But it affects IQ, academic achievement, attention, and executive function. And, you know, again, it's crucial just to follow for developmental delays. Cardiovascular disease. So the leading cause of death in kids on dialysis is cardiovascular disease. The incidence is pretty staggering. Even in 0 to 4-year-olds, 1 in 4 have evidence of early cardiovascular disease. So uremia and all its inherent complications are ripe for creating a milieu for the development of cardiovascular disease. It begins very early. CKD is considered a vasculopathic state. So left ventricular hypertrophy, common. Increased carotid artery intima media thickness, common. And cardiac calcifications can be seen common. And the most frequent events include arrhythmias, valvular disease, cardiomyopathy, of which hypertension contributes to, no doubt, and acute cardiac death. So if our kids die on dialysis, particularly if they've left us and die within 5 years of transition to adult practice, it's almost always a cardiovascular event. A lot of risks at play here. Some are obvious, like those on the bottom: diabetes, smoking, dyslipidemia, and obesity. But the hyperparathyroidism, the calcium phosphorus products due to hyperphosphatemia contribute greatly. And then if you have LVH and you have poorly controlled hypertension, which you know in the non-CKD population is a risk for cardiovascular disease. If we look at mortality overall, this is staggering. The lifespan of a child on dialysis is shortened by 50 years compared to age-matched controls. It's really significant. And if you have a successful transplant, you still have a shortened life by 25 years on average. Cardiovascular disease, number 1. Now, the good news is the 10-year survival is not as bad as that first bullet, okay? But that's 10 years, and that still means 1 in 5 die in the first 10 years after initiating dialysis, okay? Preemptive transplant means we were able to transplant you without the need for dialysis, so we more quickly normalized your GFR and you do better. Remember, on max dialysis, you have a GFR of 30 to 40. That's the best we can do, okay? And infants who are on dialysis in the first year of life have the poorest prognosis. Half of them die. Okay, so it's a very high risk population.
Half of them die by what time?
In the first 10 years.
Okay.
Now, if they die in the first year or two, it's usually a sepsis related to their dialysis. So we're going to, I was asked to include dialysis. I don't know why. I don't know what you need to know about that. So I tried to keep this as brief as I could, and I'm running out of time, so I'll try to hurry. But this is typically initiated when your GFR is less than 15, or you've hit that stage 5 category if preemptive transplant is not an option. We might start it sooner for a number of reasons. If you're volume overloaded because you have a glomerular disease and you're oliguric and you're chronically hypertensive, if you have intractable acidosis or hyperkalemia, which is really unusual because of our medical therapies, poor growth despite adequate nutritional support, and again, neurocognitive concerns. So in our infants and toddlers, if the pediatrician calls and says, I'm really worried that we're losing ground here, the head isn't growing and we're falling, we're not meeting milestones, we will consider initiating dialysis at stage 3 or 4, based on GFR. And the modality of choice is either going to be peritoneal or hemo. Each has its advantages and disadvantages, and the choice is guided by a number of things. Available expertise, in particular with hemodialysis, which we do not have here in younger children. Dr. Kramer and I can do it, but we have no staff to support us doing it. Patient preference at times. Okay, we get if we don't care which modality you're on, then we'll allow you to choose. Okay. And then characteristics of the patient, their size, weight, surgical history, social situation, and then what options we have for access. So if we look at hemo, kids under 8 in Columbia, South Carolina cannot be on chronic hemo because the dialysis unit, there's no PALS training, there's nothing to support the kids. And our pipe dream is to have an inpatient or day hospital, hopefully hemo unit for our kids at some point, we'll see. We got our 3rd dot coming in August, and then that's the next, in case you didn't know. So we're super excited about that too. You need a right internal jugular double lumen venous catheter. So obviously if you're 2, catheters are small and in many cases unavailable. And then we move on to a more permanent access, an AV fistula in kids that we can do that on. We have great vascular surgery here. The typical regimen is 3 days a week. And for our kids, it's Tuesday, Thursday, Saturday, and you have no choice in that. We round weekly, so we have to see all of you at once. So you have every Saturday of your life is spent coming in for dialysis to our unit, which is in Irma. It's the only unit in the Midlands of South Carolina that will accept kids. So geography can play a role here. Advantages, you don't have to do anything at home, okay? But the disadvantages, you have to travel and you miss school. So you're always on partial homebound because you're going to miss 2 days a week. And that's why we make you Tuesday, Thursday, Saturday, and not Monday, Wednesday, Friday. Okay. We don't give them a choice there for school purposes mostly. You can have finer control of volume in a way because you tell the machine how much to pull and it'll pull it. Okay. And you'll see in peritoneal dialysis, that's not the case. But that leads to big swings. You pull big volume, the kid's thirsty, goes home for 2 days, drinks too much, comes in heavy, and you have to pull big volume. So that can be a problem. Your EPO doesn't have to be a shot. That's an advantage. Chronic blood loss is a disadvantage. And if you can get a fistula, your infection risk goes to practically 0. But if you have a catheter, you always are at risk for a line infection. So some images of a dialysis machine that's standard, a dialysis catheter that's standard, how it's put in the IJ with the tip in the right atrium, a patient connected for her treatment, and a series of artificial kidneys. And if you break one of those canisters open, what you see is like hair filaments, like a million of them. And if you look at those filaments under the microscope, they're hollow. And so you have this tremendous surface area through that plastic kidney for blood to be exposed to dialysate and for your exchange to occur. Peritoneal dialysis can be done in kids of all ages. We do this in the NICU. Okay, so you have no age limitations. You have a surgically placed PD catheter. This is 7 nights a week, period. Okay, but you do it while you sleep. Okay, and it is far and away the preferred modality of children. Our end-stage population right now is wonky because we're down to 2 PD kids and 7 hemo kids, and we don't like that. So, if you've had chronic peritonitis, we have to convert you. If we don't trust you, we have to convert you. So we have a negative population right now. That's what that means. So the advantages, you do it while you sleep. Your days are free. Okay. No disruption to school. And then the disadvantages, you can't get a night off. All right? And that's what we tell them, but you really can't. If you make good urine and you're stable and you want to go spend the night with a friend every 4 months, we're going to let you skip, but we don't tell them that up front. Okay, it's for a lot of kids just not flexible that way. No disruption to school, but requires somebody at home to do it. Okay, better volume control because it's a nightly therapy, so you don't have the big swings. It requires a stable, safe home environment. How many of our chronic patients in multiple specialties have a safe, clean, reliable home environment? There's less dietary restriction. We don't typically have to fluid restrict you when you're on PD, for example. It does require training, takes about a week, but it is all outpatient. You have better preservation of residual renal function for reasons not entirely clear than when you're on hemo, and there's still an infection risk, okay? So in a very simple schematic, this is a manual peritoneal dialysis setup without a machine. Fluid goes in, bathes the organs, gathers the foul humors, drains into a drain bag. This is exquisitely simple in many ways, okay? And if you think about the peritoneal membrane, it is a paper thin membrane, but if you look at it ultrastructurally, those peritoneal capillaries, it's full of blood vessels. So if you put fluid in the peritoneal space and expose it to all those capillaries, there's your exchange, okay? And the surface area of your peritoneal membrane is huge. And the younger you are, the higher the surface area for your size. And surface area means better dialysis. So sterile dialysate goes into the peritoneal cavity through a catheter, is exchanged at intervals, and a prescribed dwell is programmed into the machine. Solute is removed by diffusion and fluid is removed by ultrafiltration. Okay, we use dextrose for that. So again, fluid goes in. Smaller molecules come across very quickly, larger molecules a little more slowly, but they do come across. Water comes across very readily, drains out, and the whole process starts over again. Yeah, back in Seattle, and I found it in my computer that I still had it. Yeah, are you impressed? Okay. Could I do it today? No. All right, so there are forms of PD, you don't have to know that, but things we prescribe are the fill volume, and it's usually based on surface area. We don't start at this volume, we work up slowly to allow the peritoneal cavity to accommodate the pressure. It's very well tolerated. Dwell times vary between a half hour and an hour, okay? Number of cycles are prescribed to the right there. A cycle is a fill, followed by a dwell, followed by a drain, okay? And then the dextrose comes in 3 flavors, 1.5%, 2.5%, 4.25%. And said another way, that means the glucose concentration of the solution is either 1,500, 2,500, or 4,250. So there's your osmotic gradient to a glucose of 80 in the serum. Water wants to come out big time. And the families will have all 3, and they're actually trained to make their own decisions about which solution to use. It's amazing how good they get at it. Requires a multidisciplinary care team, so does hemo, really. We prefer 2 adult caregivers, we seldom get that. There's a home visit, so the training nurse goes out to the home to assess and be sure that it's appropriate. And then we train the caregiver over the course of a week on all of these things: appropriate sterile technique, care of the exit site, how to detect peritonitis, how to set up the cycler. They get blood pressure cuffs and they keep a log of that. Again, how to adjust the dialysate dextrose based on weight, pressure, appearance of puffiness, etc. They keep really detailed flow sheets if they're compliant. And they have to have a safe, clean place to store a lot of the equipment, okay? So complications are infectious, really. There are some rare ones. If any of you have ever met King Terry, King had a pleural effusion related to dialysis, and we had to switch into hemo for that. So, but that's rare. It's usually infection, and the exit site can get infected. And in fact, 1/4 of them by a year have had an exit site infection despite their attempt at good sterile technique. Staph is the most common. We treat that orally, okay? It's usually no big deal to treat, but it raises your risk of peritonitis, and that's a more serious infection. There's a scoring system for exit sites that I won't bore you with, but that is an exit site infection. You can see the erythema, the induration, and the purulence. So that's what they look for. Peritonitis can be treated at home. That's the good news. So part of the training is how to add antibiotics to the dialysate bags. They're already taught how to add heparin once a week, okay? and they have a 3-day supply of antibiotics at home because peritonitis always happens on a Friday night. Okay, so they do have to come in so the ER can get a sample because we can't treat you without a culture, right? We need to know what you're going to grow, but if they're not septic in appearance, which they most often are not, because this is a focal infection, it's unpleasant, hurts. You can go home and get your therapy at home. Okay, treat for 2 to 3 weeks. We tailor your antibiotics to your sensitivities, of course, and this is important for the generalist too. If you're a PD patient and you go on antibiotics for anything, you must take Nystat, okay, or some antifungal. Even amoxicillin for otitis sets you up for fungal peritonitis by altering the flora. And then if you do get fungal, you lose your catheter, so it's a big deal. Empiric treatment is based on a white count greater than 100 with greater than 50% polys. So if it's less than that and the gram stain's negative and it's not obvious peritonitis, then we can wait on the culture. So upper left is a peritoneal cycler. You can see that it sits on a dresser or a shelf or whatever. It can be packed in a suitcase. I've had kids go on cruises with their PD cycler. So it's very portable. What takes up more room is the countless boxes of bags of dialysate. And the bigger the kid, the more of these you have. You may go through 4 bags in a night. So that really takes up a lot of space. Below that is a couple of examples of peritoneal catheters. They're cuffed. They have 2 cuffs. There's a swan neck version, but they're all coiled at the end. And at the end, there's all these holes. Okay, and so that where fluid goes in and out. The cuffs provide anchoring in a subcutaneous tunnel that surgery creates. Middle above is dressed, below undressed, and anybody can get PD. So it works really well. Okay, 8 minutes late. What questions do you have? A lot of ground to cover. Sorry for the rapid fire finish. I thought, oh, and I'll include transplant. No way. Back to the uremia. The direct effect of uremia on brain growth is probably where that lies. Yeah. All right. I don't see any chats either. So, okay. Thank you guys.